Hello, everyone. Good morning, good afternoon, good evening, wherever you're joining us from around the world. And welcome back to another episode of the Realist Lens for researchers who keep it real. Today, we're diving into a powerful and timely topic: how transformational treatments can reshape clinical care and how realist evaluation can help us make sense of that change. We're talking about ETI, a game changing therapy for people with cystic fibrosis in the UK, and how it's not just improving lung function, but also shifting how care is delivered, how people engage with treatment, and how professionals navigate uncertainty. To help us unpack this, we're joined by someone who's gone deep into the real world impact of ETI using realist evaluation. From developing program theory to integrating interviews, surveys, focus groups, and even regression analysis, today's guest has done it all, bringing theory and practice into conversation in a way that really matters. We'll be talking about navigating multiple methods within a realist framework, engaging with diverse perspectives from clinicians and people with cystic fibrosis, and reflecting on how a researcher's own position can shape that process. And who better to guide us through this than Rob Sandler, whose recent thesis does just that. Rob, welcome to the Realist Lens. How are you today?
Hi, Alejandro. I'm great. Thank you. Thank you for having me. It's a pleasure to be here. How are you?
Yeah, I'm very good, thanks. The pleasure is mine, Rob. Thank you so much for being here, for being an avid listener of the Realist Lens. And first of all, congratulations on your Viva recently and passing your PhD. How are you feeling?
Thank you. Yeah, it's a great relief, isn't it? I actually really enjoyed the vibe. Obviously, I was very anxious about it beforehand, but it was a really good conversation about my work. And yeah, great relief to have passed that milestone for sure.
Yeah, certainly it's a fantastic feeling and very well deserved after the hard work that you've gone through over the last few years. And it's great that you enjoyed it as well, because I feel that it can really be an enjoyable process. At the end of the day, you'll be the one that knows your work more than anyone. So talking around that in a pressurized, but also, as you say, exciting environment can also be very gratifying. I've mentioned a little bit about what we're going to speak today, Rob, but it'd be great, please, if you'd be able to just quickly introduce yourself, your background, and also a bit on the background on the context, please. So, I've mentioned around ETI, cystic fibrosis, and all these different areas. So, would you mind just sharing a little bit more as well for the listeners to understand what the conversation's all about today?
Yeah, absolutely. So I'm a medical doctor by background. So I've been practicing for around a decade in the United Kingdom, based in Sheffield in the UK. So I am actually a rheumatology doctor by background, and cystic fibrosis isn't traditionally a condition looked after by rheumatologists. So I was very new to it when I started my PhD. So I've just finished a 4 year PhD in health services research at the University of Sheffield. And that PhD was really exploring the impact of rapid change in the treatment landscape for a long term condition. And in this case, cystic fibrosis, or CF, as we'll abbreviate it to. So I'll just give you a bit of background to CF and also what this massive context change was and how that shaped my work before we dive into some of the stuff I did. So CF is an inherited condition and it affects around 11,000 people in the UK. Historically, it was associated with a very limited life expectancy. So in the 1960s, someone with CF may have a life expectancy of around 10 years. But with improvements in care and treatment, many people are now living into their 50s, 60s, and beyond. But still, the life expectancy falls behind that of the general population and always has done. A key problem medically in CF is that you get the buildup of thick secretions, and particularly in multiple organs in the body, but particularly problematic in the lungs, thick phlegm or mucus. And this leads to chronic infections and inflammation that causes damage over time. And that's usually the thing which contributes to this reduced life expectancy. So, to manage these lung issues, people with CF are prescribed historically inhaled medicines. So, these are all called nebulizers, where you take a liquid medicine, you put it into a device, it turns it into a vapor, and you breathe it in and out for between 2 and 10 minutes, depending on what drug it is. And what they do is they thin that sticky mucus, and they also contain antibiotics to fight any infections that are down there. So, the problem with those treatments is that they work, but they're very burdensome. It can take 5 to 20 minutes to actually inhale the medicine. You've got to clean the machine. You've got to maintain the machine. There's a technique to it. It's much more difficult than taking a tablet, for example. So as a result of that, adherence, by which I mean how much of the medicine that's prescribed is actually taken by the patient, is very low. So the previous studies have shown that adherence to inhaled medicines in CF is only about sort of 25 to 30% when you look at real world data. So for every 10 doses prescribed, only 2 to 3 are actually taken. So At the start of my PhD, what I was studying was the implementation of a complex intervention, which is called CF Health Hub. Now, this supported people with CF to build habits of using their inhaled medicine. So it's a habit formation intervention, which also had a digital platform that collected accurate adherence information from nebulizer devices that actually electronically log when one is being used. So you're not reliant on people remembering or reporting whether they've used their medicines. It's all logged passively and electronically. So this was sort of the setting of the PhD, and this is the sort of the context of CF care around the time when I started, which was 4 years ago. However, shortly before I began, and this is where we get into our next acronym. So when I began the PhD in 2021, just before that in 2020, a few big things happened that our listeners may remember. 2020 was a big year, but a big thing in CF was the availability and introduction of a brand new tablet treatment. And this is that treatment which it's called elexacaftor, ezacaftor, ivacaftor, because it's got 3 drugs in it, and we abbreviate that to ETI because obviously the other one's a bit of a mouthful. And people may also know it by the trade names, which would be either Kaftrio in the UK or Trikafta elsewhere. It's the same drug. I'm going to try and keep calling it ETI because that's the correct name for it going forward. So this treatment, unlike those inhaled medicines I talked about, this actually works at the molecular level and it corrects the underlying defects in cystic fibrosis. So it doesn't just treat infections and thin mucus, it corrects the protein problem that leads to that mucus being thick. And, that has totally revolutionized CF care. Many people are experiencing much better health as a result of it. And that was made available in 2020. So this transformation was rapid. And now there's a new uncertainty really about the role of the older, more burdensome but established treatments like the nebulizers. What role do they have? Now I've got this tablet that makes me feel great and thins my mucus. And, by extension, what's the relevance of interventions like CF Health Hub, which were designed to support adherence to the old medicines, which are now being questioned in terms of necessity? So that was the background to the sort of the context of the study. And that's why I thought that realist evaluation was a good approach to take when studying this area. So I was studying a complex intervention that was being implemented in real world settings and during a period of rapid change. So realist evaluation kind of offered a way to understand not just whether this CF Health intervention was working, but as we like to say, how, for whom, in what circumstances, and why. Because what was clear is there was a lot of variation going on, particularly because of the disruption by ETI. But also, don't forget, we also had a global pandemic in 2020 as well. So that totally added to the disruption in terms of models of care and virtual versus face-to-face remote monitoring. So all this big mishmash of context was happening in the background, but it was all directly relevant to how is this complex intervention going to land in the real world. So so that's a bit of background to the work and a bit of background to CF.
Love it, Rob. Thank you so much for sharing that. And I love learning new things. And I love hearing about your passion on the topic as well. And also, such a great justification for the use of realist, in a complex, dynamic setting where, as you mentioned, there's so many layers going on here. And it appears as well, what's interesting, that probably when you started your PhD, or at least when you were thinking about it, this just came. So did you probably had to reshuffle a little bit the focus of the PhD as these things came along, right? Which again, part of the iterative nature of the realist approach. And so thank you for sharing that. And hopefully all listeners as well now, when we're saying CF or ETI, we also know what we're referring to here. And of course, during 4 years, you've been exploring exactly that, how ETI has reshaped cystic fibrosis care in the UK. And so you've mentioned a little bit around what made you choose realist evaluation. So how do you start to shape your initial program theories then? Because obviously in such a fast-paced context and with so many things going on, and probably with little to refer to, you probably could go through similar we mentioned of camera, for example, with HIV treatment, there was a big contextual change as well. So you could probably lead on some of that. But with this fast-paced context, this new intervention, how do you begin shaping your initial program theories in your evaluation?
Thank you. So it was tricky because not only was it obviously the landscape of CF had changed, but I was also new to CF. I hadn't really, I'd studied it at medical school, but I didn't really know much about it as a physician prior to starting this PhD. So I was sort of educating myself on the condition as a whole, as well as all these changes that had happened. So the IPT was really shaped by my dual role during this process. So I was part of the CF Health Hub Central team. That's how I was kind of brought in to evaluate the implementation efforts. And I was also working clinically as a doctor in a CF centre, local to where I work. So to form my initial program theory, I drew on previous documents that have been published about the CF Health Hub intervention. So the training manual for people who are training to deliver the intervention, the publications, there's quite an extensive literature published from the group as they were developing the intervention from my colleagues. So I drew on that. I also, in terms of my perspectives on what is best practice for treating CF in the post-ETI era, and that was very much shaped by my colleagues. So how my colleagues at the centre I was working were practicing, and that was, different to where colleagues elsewhere were practicing because there is variation across the country. So that shaped some of my thoughts and feelings. In terms of actually articulating this as a program theory, I found that it was during the first phase of data collection, actually, because I wanted to. So the project had been through a few iterations in terms of what am I going to be evaluating here, and I had some ideas about what should be working and how. But I actually felt, to be honest, the best insights for the initial program theory came from my first phase of data collection, which was interviews with 11 CF clinicians from a range of disciplines from 8 different CF centres around the country. And I was asking them about, how has their practice changed since since ETI has come along, how have their experiences of the CF Health Hub intervention and approach changed. And it was really, I'll be honest, I found those interviews were the thing that really helped me shape my initial program theory, and then that set the stage for the rest of the work thereafter.
Fascinating. So if I had to summarize those 3 steps, or from what I hear, is that you consulted the literature, number one. Number two is that you had your own initial hunches from your work as a clinician, but also that you spoke with relevant key stakeholders. And those 3 kind of branches helped you develop this initial explanation, a prototype I like to call sometimes, like this prototype that we're going to go and test. Would that be fair, those 3 things?
That is a beautiful description of what took me about 5 minutes to try and explain. So thank you for articulating that so concisely. I'm very
Yeah.
much sure that if I can say something in 100 words, why would you say it in 3? But yeah, no, I agree. Yeah, those 3 steps, that perfectly captures what I did. Thank you.
Fantastic. No, thanks to you. And I think that's brilliant. I think it gives people as well the understanding that this initial explanations as well, that's what they're for, that they're initial, and they're going to give us that guidance into where to take us. But of course, the expectation is that they will be adapted and refined, refuted, or confirmed as the evaluation progresses. And in your case, you brought together a range of methods to do that, from that initial explanation that you had, that prototype, with interviews, with surveys, with focus groups, and also with some statistics. So, how did you design and sequence these elements within a realist framework? And how did each contribute to theory of refinement? So, first of all, with all these multi methods that you used, because of course we know realist evaluation is method neutral, how did you choose at what stage to place them within your evaluation? Number one. And then, how did each contribute to the theory of refinement?
So the data collection was designed in stages that aligned with realist principles, in that I moved from sort of exploration and generation of theory to testing and refinement. So, as I mentioned, my initial stage of data collection was interviews with key stakeholders around the country. So that allowed me to be exposed to a broad range of perspectives on the way that not only the CF Health Hub intervention had been impacted or was being delivered in their centre, and what was leading to that, but also what has COVID and cafeteria meant to these people across all these different settings. So it really helped paint a picture, a UK-wide picture really of what was going on. But I wanted to approach, those theories with a really open mind. So I had some things I wanted to explore, but I really kept it very open. So I didn't want to close down any doors, particularly at that early stage. So what became very clear is that I hadn't initially thought I was mainly going to be focusing on what are people's thoughts around inhaled medicines, what are people's thoughts around CF Health Hub, the intervention. But actually what became very clear was that the changes to virtual care and the way that care is being delivered after COVID that had come in at the same kind of time as ETI, that was clearly a really important thing for all the stakeholders. So, I took that and thought, well, I'm going to run with that. So that was kind of, that helped me develop areas of theory that I hadn't thought about prior to, didn't have any hunches on. And it was just stuff that came out of the interview. So being open-minded allowed me to sort of keep the inhaled medicine stuff, which I wanted to go out and evaluate, but also identify that the changes to the model of care in terms of virtual, face-to-face and hybrid models, that should be evaluated further. So my second stage of interviews were focused on clinicians at a single centre. And these were at that point more targeted, because what I really want to know is a bit more about how are you delivering this intervention in the new context. I've got a nice background from the multi-center interviews, but I did want to really hone in on practitioners of the intervention at one center in a much more detailed way. So I refined theories around the barriers to adherence support, but also I uncovered adaptations that were being made to the intervention. So, for instance, the CF Health of Intervention was designed to involve scheduled face to face reviews and structured behavior change planning. But clinicians were telling me that actually patients, a lot of the time, because they're experiencing improved health from having been taking ETI, they don't really want that anymore. They don't want to be spending a long time writing in plans. They just want quick check ins. They just want a text to help with their adherence. So what was challenging there is that the fidelity of the program, because I mean, this was a very, very theoretically robust intervention, really aligned with the NRC complex intervention design frameworks. It had been evaluated in an RCT as well. So the fidelity of the program was drifting, but not in error. But it was in response to changing preferences from patients, which I think is one thing that happens when you go from a trial environment to the real world. You do need adaptability and flexibility, but you also need to balance that with the fidelity to actually deliver change. So the adaptations raise very important questions about whether the intervention was still achieving its aims or not, based on these adaptations which were having to be made. So that was very interesting and very complex. And again, Realist interview really helped me sort of pick that stuff out. What came out of all that data collection was that a key driver of everything that was going on was what patients, the people with CF themselves, were thinking and feeling. So I then thought, right, now is the time to include their voice. I was always going to do it at some point, but I thought I felt more comfortable as a clinician just speaking to clinicians initially, getting my head around everything, and then going to speak to the patients with lived experience themselves. So I designed a short survey for people with CF, again, mainly to test theories that had come from the interviews around the adherence to inhaled medicines and what was affecting those decisions in the current era. So I asked them in the survey to rate their perceived importance of inhaled medicines and also denote if that had changed since they started on ETI. I did leave a free text box in that survey because, I thought, well, people might want to say something. I didn't really necessarily expect much response. I just thought people were going to put a full stop. I left it optional, so people are just going to leave it blank. But I've learned something about people with CF, and that is that a lot of them have a lot to say. And if you give them a chance to say it, they will tell you. So we distributed this survey to about 1,600-ish people with help of the CF Trust, which is the national CF charity. We got over 400 responses, which was great. And actually, almost 300 of them left free text responses. And those free text responses were sufficiently detailed to allow me to actually categorize the insights and to actually shape some more theory around what is driving those decisions around adherence and identify some of the patterns. And I built that into my theory. And what was challenging then is at that point, I learned that the CF Health Hub program was actually going to fold. So it had exhausted funding because of just the rapid change in the treatment paradigm. Much less emphasis was being placed on the inhaled medicines now. And as I say, CF Health Hub was an intervention and digital platform to support adherence to inhaled medicines, not specifically for the ETI, the new medicine that was, that had changed the treatment landscape. So this was obviously very stressful for me because I thought, oh my God, my whole PhD is falling apart. The program I'm evaluating is closed. How on earth can I possibly, what program am I evaluating? What is my program theory? What is the program? It's closed. How is this going to be useful to anyone? So what that forced me to do really was to think more broadly. So I separated my theories at that point into theories that were CF Health Hub program specific and theories that were more context specific. And as CF Health Hub was now closing, I was able to prioritize the more context specific theories, again, around thoughts and behaviors related to inhaled medicines and virtual models of care. So the final stage of data collection there was then focus groups. So these were focus groups with people with CF that were designed to refine and test the theories that I'd been developing, particularly around the role of habit formation and routine. And how important they seem to be in terms of the adherence to inhaled medicines. And also the other thing is, you remember I mentioned that the clinicians had talked about this move to a virtual and hybrid model of care. Well, patients also had lots of views about that as well. And for some, they experience this as very liberating. They're no longer having to come to hospital every 6 weeks and sit for hours and have all these things done. They're looking to reduce medical intrusion. But for others, they were feeling abandoned by their care team. They were so used to that very holistic model of care that was quite a burdensome model of care where they're going to the hospital very frequently. They're having frequent admissions for chest infections. Well, now that they are so much better from taking ETI, their requirement for this care, at least from the hospital's perspective, is diminished. But in the hospital are saying, go and live your life. You don't need to see us so often. You're so much better. But actually, for them, for some people, actually that was more than just a transactional health relationship. They actually feeling abandoned as a result of these rapid changes to the model of care. So that was the final sort of qualitative data. And then you mentioned as well, I did a regression study as well. So this was kind of like a post-theory quantitative test, really. So I was able to test some elements of the program theory that could be quantified, particularly relating to habit and treatment-related beliefs. And I used routinely collected data from the NHS electronic patient record and to explore the associations between 25 different factors and objective adherence to inhaled medicines collected from the CF Health platform, from historic data within the CF Health platform. So of those, 5 factors had statistically significant relationships with adherence that related to my program theory, and one in particular, which was actually habit and self-reported habit strength, which formed a big part of my theory, that had overwhelmingly the biggest impact on it. So that was really useful because it helps validate habit formation as an intervention to try and improve adherence. But that was sort of the sequence of the study. So I can also talk about how I applied the realist logic to the data, and because that was quite tricky. But I don't know if you had any questions for me just on that sequence of the study, and if you'd like me just to talk briefly about how I actually applied the realist logic to the analysis.
I just feel that you've taken us, like if we were at the theater, we've just gone behind the scenes with all the lighting and the cables and all the logistics and mechanics to make something work. And thank you for sharing that, because I think that many students or people doing an evaluation and all those day-to-day mechanics and decisions in a study is very hard to put because you have word limitations. But actually going through the process and thinking around how each of the data collection methods were used in order to help you refine those. I think that was really valuable. So thank you for sharing that. And yes, please, I would absolutely love to hear more around the realist logic of analysis then in all those different areas. Because of course, everything that we're trying to do within this realist logic is to refine, refute, and confirm program theory. But within the focus group, interview, or survey data, that probably was slightly different.
Absolutely. So this was something I really struggled with when I started. I felt I kind of got my head around what realism is trying to do, but then it's a case of how do you do it scientifically, in a rigorous way that will stand up to scrutiny and will actually be robust and give you reasonable findings, accurate, what you would hope be accurate findings. So to start with, my data were interview transcripts. So I did an interview with someone and I reviewed the transcripts line by line to identify interesting quotes and start to help build initial theory statements. So, for example, a quote I might have got in an interview was, I've got the patients with CF who are not on ETI and they're really engaged with their inhaled medicines. So that'll be a quote I get. So I look at that and I say, okay, so that's giving me some feature of context here. So people with CF not being on ETI, that is a contextual feature whether you're on ETI or not, because not everyone is eligible for it or taking it. And we also get an outcome, which would be that an outcome or a mechanism, depending on how you look at it, engaging with their inhaled medicines. So from this quote, there appeared to be something that contextual factor of whether someone is on ETI or not appears to be influencing the engagement they have with their inhaled medicines. So that kind of gives me, some theory fragment. So I start off with an if-then-because statement for that. So I've got, if someone is not prescribed ETI, then they will engage more with inhaled medicines. So that was just turning that piece of data into an if-then-because statement. But of course, what that doesn't give me is a mechanism. So it just gives me, as I sort of saw this as more of an outcome, as the engagement as more of an outcome at the moment. So therefore, I used retroduction. So another thing which obviously realist approaches celebrates is the role of retroduction, which I really enjoyed. So from what I kind of gathered in general, it was the improvement in symptoms that people with CF experience from ETI that leads to that reduced engagement with the older, burdensome inhaled medicines. So I used retroduction to propose that mechanism. So the statement then became, if someone is not prescribed ETI, then they will engage more with inhaled medicines because their symptoms have not been reduced by ETI. So I used retroduction there to try and form an if-then-because statement. So this is how I kind of went through the transcripts and the data. So this approach led to the generation of a number of theory statements. And over time, I moved to writing these as sort of CMO statements rather than if-then-because statements. So it's similar kind of stuff, but just written in a slightly different way. And I ended up with over 70 after the first 5 interviews. So what I did is I categorized them into buckets. So theories relating to mental health, the changing nature of chest infections, clinician behavior, patient behavior. I consolidated them where I could. So I sort of, was going back round the circle and checking, are these theory statements related? Could they be built into one? Just to reduce the number I'm working with here. And then I just kind of went through that process as I went. So the kind of the steps I took was I'd identify an interesting point. I'd look at my current CMOC index. If what this new piece of data either supported, developed, refined, or refuted a CMOC, I'd build it into that CMOC. If not, I'd consider a new CMOC. And then I kind of rinsed and repeated for all my qualitative data that came through. So that was the main way I did it. In terms of the survey, by asking people to indicate whether they thought that inhaled medicines were less, equally, or more important than before, after ETI than before ETI, that almost gave me an outcome and a way of grouping the respondents. And I could look at the free text responses that were related to those who think that inhaled medicines are less important versus those who think they were equally as important, that allowed me to try and unpick, well, what are the things that they're telling me that are leading to that particular thought and perspective, which appears to be driving behavior around adherence. So that was kind of how I used those different data points all consistently within this ever-growing Word document of theory statements. One thing with that I thought was really challenging though is like, what do I actually put in my methods section? So, if you put, I used the regression analysis, I used framework analysis, I used thematic analysis, people kind of know what you mean. But what do you call this? Like, do you call this realist analysis, a realist approach, a realist logic? And like, what does that even mean? And, I think one thing that I think the community would benefit from would actually be a slightly clearer definition and naming of the method itself. So one term I did find really useful, and this came from Nielsen and Lemire's chapter in the Realist Evaluation book from Manzano and Williams, was constant comparative method, which is used to describe the process of comparing each new data unit, which in my case was an interesting quote, to the previous data, which was my CMOC index. So that I found helpful as a way of describing the method and using terminology to describe the method. And as I said, I did all this in like a living Word document. So it was a beast. It was a big old document. And each CMOC would have its own page. It was categorized into those buckets, sort of conceptual buckets that I described. And when a new piece of data was relevant to that CMOC, I'd copy it in and I'd make a note of which elements of the theory that supported or refuted. If I then needed to do another version, I'd just do version 2 below and say which elements of that version were contributed from this new theory statement. And so it just kind of snowballed my way through it in that way. The other thing I found really helpful actually was using generative AI models. So these are very powerful tools, but you have to be very responsible in how you use them. So what I found really helpful was I asked it, to give me feedback on the way I'd constructed some of my CMOCs. And I also asked it to suggest some names. I described the mechanism that I thought I'd come across, but I felt I want to name this mechanism to try and make it understandable and transferable. And I actually found that using generative AI to help me just articulate some of my CMOCs and also name some of my key mechanisms was really helpful. But obviously, a lot of the stuff it spews out is rubbish. But in there are some nuggets, and I think if you can use it responsibly, I found that really helped, particularly towards the end of the work. So I was like, I need to get this finished now. Really helped me consolidate and articulate my thoughts. So that's how I applied the sort of the realist logic throughout the study.
Fascinating, Rob. And again, similar to your previous answer, of taking us behind the scenes of everything that is going on in the final product. And I think that is such a useful and fruitful way to go through your analysis. And also importantly, how you connect them all together, because again, it can be slightly overwhelming to have this big Word document with so much data and so much information, and how to make sense of it from a realist perspective. So thank you for walking us through all that process. And I got to say that again, that is a really good chapter by Nielsen and Lemire as well, that you mentioned. And what they vouch for is to have a really clear analytical strategy, and it appears that you had that in your work. So thank you for sharing that. One of the things that has intrigued me from the people that you were talking is that you've engaged both clinicians and people with cystic fibrosis. And I know that you mentioned previously that you uncovered some tensions around treatment adherence and decision making, particularly in this changing concepts and changing context when you have people, that are having the previous treatment. Now there's this new treatment. Some people love it, some people resist it, and there's so much going on. So, how do you use realist tools to explore this perspective and make sense of the mechanisms of it? Because, of course, all these different voices and all these different actors, it's so useful, but at the same time, it can be overwhelming.
Absolutely. So this tension or mismatch between clinicians and people with CF became one of the key findings of my work. So I eventually labeled it epistemological dissonance, which again was something suggested to me from a generative AI model that just I thought that actually perfectly captures what I'm trying to say here. I've spewed in a whole paragraph of I'm trying to describe this, and I'm going to tell you what that is. How would you name it? And it gave me that, and I was like, wow, that is actually what I'm trying to say. So what it is it was a fundamental difference in how each group understood and valued evidence of health. So through the interviews initially with clinicians, it became very clear that clinicians, when they came to making decisions around is someone with CF doing well or not, and how is that going to influence the treatment recommendations I make, they tended to give more weight to objective markers of health. So in CF, we use a measure called lung function, which is where you take a deep breath and you blow out into a tube as fast as you can, and it measures the volume of air that you puff out in the first second. So it's called FEV1 is the abbreviation, but we call it lung function in CF. And that is the key sort of lung health measure in CF, one of the most important ones. And that was clearly a really important thing for when clinicians are making decisions regarding people with CF they're looking after. Whereas subjective features such as breathlessness, energy levels, fatigue, of course, they were acknowledged, but they seem to carry less weight in guiding decisions and recommendations. When I interviewed people with CF, however, they often place much more emphasis on how they felt, so their day to day symptoms, their sense of well being, their energy levels, rather than the actual number that comes out when they blow into this machine. And this difference in sort of epistemological stance, which is kind of an objective primacy coming from the clinicians versus a subjective primacy coming from the clinicians, had become more pronounced in the post sort of in the ETI era, because changes in the objective health markers no longer aligned with the subjective health markers. So in the past, if someone's lung function had dropped down by half a liter or something, they would usually feel worse as well. They'd have a cough, they'd feel breathless, feel unwell. But ETI has introduced this new complexity where even when markers like lung function go down, people with CF are still feeling so much better than they were. They're not recognizing that they're unwell, and there's this sort of mismatch between how they feel and what their numbers are saying. And that creates real uncertainty about whether to continue treatments, reduce treatments, change treatment regimens. So I used several realist tools to explore this. So first, I kept asking why questions in interviews. So moving beyond sort of service level responses to really try and I hope it didn't feel like an interrogation to some of the participants, but just asking why questions. And when the mechanisms underpinning why people were behaving in a certain way or thinking a certain way, when they weren't made explicit in the interview, that's when I employed retroduction to theorize on these hidden mechanisms that were underpinning what I was described. And then thirdly, by constructing separate CMOCs for clinicians and people with CF, and when it came to reviewing the CMOC index throughout the process, that's when I noticed this divergence in sort of epistemological stance on what is evidence of health. Is it how I feel or is it what my lung function is doing? And that is it was actually by doing a CMOC index table that I realized, looking at it, all online, was like, okay, there is a mismatch here. And that seems to be really important. And that seems to be driving tension and concealment of behavior. And it was driving professional disempowerment where clinicians are saying, I might recommend stuff, but they're just going to do whatever they want anyway. They're not, I don't feel I have much agency in this process anymore. It's really driving a lot of challenges for both clinicians and for people with CF as well. So yeah, that's what I would say about how I used realist tools to explore that particular phenomena.
Thank you so much. And again, it's so interesting that that particular phenomena, if you keep it at surface level, it can really get into those tensions, but not get into the detail that you've mentioned there of retroduction and why questions and really understand the reasoning behind those, which of course is what we're trying to do from a realist perspective. So that is really useful. And talking about going deeper and engaging with the data and the topic. I think that one of the key characteristics as well within your work, Rob, is that you're a clinician yourself as well. And I think that there'll be many listeners here who are going into realist work, but they're also bringing their own experiences, their own clinical experiences, and their own thoughts into the evaluation process. You acknowledge reflexivity in your thesis, and I just want to scratch on that a little bit, please, because were there moments where your own assumptions or your role influenced the theory development or interpretation of data? And from a realist perspective, how was that useful?
Yeah, so I mean, even before that, just encountering realist evaluation as a research approach felt like stepping into a different philosophical universe. So, I'm trained as a physician and, I'm trained in evidence based medicine, and the RCT sits at the pinnacle of evidence. So, when I began using things like retroduction to infer hidden mechanisms, I was quite worried that it seemed very subjective, this kind of just my thinking. And I recall one meeting where I was explaining this to a colleague, in the hospital, and they were like, "Oh, so you've just made it all up then?" So that kind of stung at first, but it also forced me to really try and articulate the logic that underpinned the approach. And I even found myself asking, well, where does realist evaluation actually sit on the conventional evidence hierarchy? So in one sense, it's very rich information, but derived from a series of cases, which occupies, case series will occupy a very low level on the evidence-based medicine hierarchy. But when it comes to actually evaluating a complex intervention in the real world, these insights can provide much more useful information than those that you can gain in a classical RCT, for example. So, both methods have their place, but I think the role of realist evaluation, certainly for a clinician, is not that well defined at the moment. And that was something that I struggled with, and something I really had to think about. But on a more practical level, about my own assumptions, I didn't have clinical experience in cystic fibrosis prior to this PhD. So as I mentioned at the start, I arrived very curious about CF, but also quite naive. My views were really shaped by those of my colleagues and the practices in our centre. Being part of the CF Health Hub Central team, also I was surrounded by enthusiastic colleagues who considered adherence support through CF Health Hub as best practice. And, there's evidence to support that. And, I worked in a team where we hadn't actually really adopted virtual care after the initial waves of the pandemic. So, when it came to yeah, I didn't really have much thoughts on virtual care because we don't really do much of it where I worked. So, that was interesting when I came across that in my first interviews with key stakeholders. That was really important all around the country, but it was just something I didn't have any exposure to. So, I was, also in the centre where I was working, we took a very cautious approach to people who'd started ETI reducing or withdrawing their inhaled medicines. We certainly didn't actively encourage that in most cases. So I was much more familiar with the logic of caution around that approach. But at other centres, they had a much more permissive approach to that kind of experimentation with treatment regimens. So, it was quite challenging to come into an area new, have my views shaped, in one particular way, but then also have them challenged as part of the data collection, which was part of I think the really good experiences for me as the work, but it definitely was challenging. When I was speaking to clinicians at conferences, not just in the research, but also like at conferences, just getting different competing viewpoints on, what might be done differently and why certain things are happening was really, really useful. And it really did challenge some of my assumptions, but also develop my thinking. So yeah, I would say those were the kind of main ways that, my assumptions were challenged and shaped.
Fantastic, Rob. Thank you so much. And I think that what you've done here as well is just share some gaps that I think the realist community can really go into. So you mentioned one very interesting one, which is the role of realist evaluation for clinicians and where it sits. So I think that's a really interesting one. So I'm sure if anyone is listening that wants to speak to Rob about that, I'm sure he'll be very happy to speak. And also just the process of reflection. It's interesting that comment you say of so it's all made up then. I wonder how that made you feel as a clinician, but you didn't give up and you're come out with a realist PhD. So that's fantastic. Because of course, I always call it the glasses, right? That you've seeing the world and viewing the world, and no glasses are better than the other. They're just helping you to see it from different angles. So it's useful to see that you continued in the pursuit of realist knowledge. Rob, it's been fascinating hearing you and going into all the background, as I say, like the behind the scenes, so to speak, of your PhD, of your thinking, of your rationalization, of a very complex and dynamic topic. And I guess that many people listening to this as well, either doing their PhDs or maybe they're embarking into realist evaluation or realist research from a clinical perspective as well, they will have found it really useful. From everything that you've said, and there's a lot, and I'm sure that we could keep talking as well. There's so much to say. But if you had to summarize three main tips or lessons you would offer to realist researchers, particularly clinicians, that may be working with realist evaluation, and they'll be leaving the podcast and go to their projects, to their research, to their work, what would be your top 3 tips to offer about realist study design, managing complexity, or staying grounded in real world practice?
So the first piece of advice I'd give to anyone starting out on this kind of journey is to get some formal training. So, I think in the previous episode of the podcast with Jeff Wong, I thought, very beautifully captured how it can be just so overwhelming, to get into this area, particularly as a clinician who comes from a totally positivist, evidence-based medicine background. So get some formal training, without some structured guidance to get your head around realist language and logic is very difficult. So I went on the CARES summer school that Justin Jagosh runs, and that was the most transformative experience of this entire process. Excellent, excellent introduction. And also at that point, I was kind of midway through the work actually to really give me the confidence to actually go away and do this work. So I'd strongly recommend finding some formal training as part of it as early as you can. I came to it a bit too late, but it was still so useful. I wish I'd done it a year or two earlier. I'd say what you mentioned before about realist evaluation being method neutral, I think just remember that it is method neutral. So there's no one size fits all method. Just think carefully about the resources you have and the skills that you have as well. So, you might have the capability to do interviews, surveys, documentary analysis, quantitative testing. You might not. But whatever it is, what I have learned is that a realist logic can be applied to that data. I know, there's caution around if you don't design a study a realist way, you can't collect realist data. But I think you can apply a realist logic to a lot of stuff, especially if you are collecting it as primary data collection, in the way you ask the questions and the kind of data you collect. So just remember that it is method neutral. And just because you can't do a certain thing that you've seen someone else do doesn't mean your work won't be valid, as long as you supply a consistent logic throughout the work. And then the third thing I'd say is try and find like a realist lab group or a network. And even if it's just one or two other people locally or remotely that you can just talk to and download about this stuff. So I didn't really have that. We had quite a small group and people within the team had left. So I never really felt I had that. And I think I missed out because I would have quite enjoyed the chance to talk through with some more realist thinkers about my logic. That summer school actually gave me the first chance to really talk with realist researchers about my research outside of my supervisory team. And I made some friends, through that, and people I've kept in touch with thereafter, and that's been really helpful. But I wish I'd had more of that network when I started. So go out of your way to kind of get some formal training. Remember, you can apply realist logic to a lot of things, so don't worry what resources you're working with, and also try and get a realist network around you for that kind of support.
Rob, you've summarized them for me there very nicely at the end, and I can completely agree with everything that you mentioned. And it's interesting you say that because so many people have mentioned that last point around the realist community and joining communities of practice and having conversations, because it is a very friendly community and many people are very open to share and to guide and to provide that support and mentoring. So I certainly would recommend that as well. So Rob, thank you so much for your time. I've absolutely loved it. It's been brilliant to hear about your journey around your project. Congratulations again for finishing, and I'm sure that it won't be the last time that we speak. Please come back to the Lens and have another conversation with us in a few years' time or in a few months' time. Whenever you want to come back, you're always welcome. And for anyone else listening, thank you so much for joining another episode of the Realist Lens. I'll see you soon. Rob, thank you so much.
Thank you, Alejandro. Thank you, listeners. Bye for now.